And we're beginning. Okay. So this is really, I mean, there's a relatively straightforward way to frame it. I'm using this PowerPoint sequence because I like it a little better for the explanation, and I'll go back to the other one at least. I don't think we'll finish this chapter today, which would conclude the exam material, but surely on Wednesday we'll do so. And so, effectively, after we saw the electrical activity last time, the electrocardiograms, and the concept of arrhythmias, the way to, bless you, the way to obviously understand it is let's assume everything goes right, the way it's supposed to for the vast majority of people. This is what you hope to see, particularly for young and healthy individuals. When we test them in my advanced lab, you don't see anything abnormal. That's the difficult part about being with folks who are young and healthy. Very rewarding for you, tough to show bad stuff. So systole, contraction, diastole, relax, not just the heart, effectively any muscle that's an appropriate term, blood vessels particularly. So heart and blood vessels, we use the term systole and diastole a lot. So the whole idea of the cycle that are there, blood flowing through the heart during one complete heartbeat. So whether it's going to the pulmonary circuit or systemic circuit, same thing. Atrial systole and diastole are followed by ventricle. So it's a two-step pump. We talked about that. Pressure and blood volume change. Mechanical events come after the electrical events, and seen on the cardiogram. So left side starting with total relaxation. So by definition, when the heart is completely relaxed, effectively we're starting a cycle. We are going to get to this. Like I said, coming up, the ball game is here. That's what we're looking for. So we try to marry all of those things as well as things that you see on the cardiogram together. So that's where we're sort of heading. So when the heart is at rest, this is when it begins to fill. After the relaxation of the ventricles, effectively what happens, what is present is the resting stage. And we'll get to why it happens. The aortic and pulmonary semilunar valves are closed because the ventricles have relaxed. The atrioventricular valves, the tricuspid and bicuspid, are open. That means when your heart's at rest, effectively it begins to fill. So once the ventricles have stopped contracting, and effectively it allows the blood to return. And that we call that ventricular filling. It happens maybe midway to the latter portion when the heart is relaxed after that completed heartbeat. Relatively, the pressure inside of the heart, meaning the muscles are relaxed, particularly the ventricles. 80% of blood passively. That's what I mean. You don't have to worry about filling the ventricles for 80%. That's the whole idea of the atrial contraction, is to top off with that other 20% through the open atrioventricular valves into the ventricles, because the semilunar valves are closed. I will show you why. So at that point, atrial depolarization, if we come to the end of diastole, what signals the start of it is the onset of the P wave. It depolarizes the atria, they contract and push that remaining 20% of blood into the ventricle. Okay? So things we look at are the end diastolic volume. In other words, how much blood got in there passively. That's an important measure. Okay? So that's something, the whole idea, and I've said it a couple of times, is to try to optimize is a better word, each time the ventricles contract. Each time your heart beats, you've got to pump out, both to the pulmonary and the systemic circuit, the maximum amount of blood that you can. Anything less than that is on a slippery slope down to what we call heart failure. And so once that end diastolic volume, now we top it off. And so at the end of diastole, we basically come up with a volume of the blood in each ventricle at the end of ventricular diastole. So we're going to look at that, because at the end, when the ventricles relax, we want to make sure there's blood left over. You'll see that in a bit. So depolarization then spreads to the QRS. By way of the QRS wave to the ventricles, the atria are finished contracting almost simultaneous to that. They relax while the ventricles begin to contract. And what happens as the atria relax, the ventricles, and it's a good word, isovolumetric contraction. We're not going to, at that point, the volume is not going to change. Because what you're going to see is the pressure occurs. Think of it as a closed circuit. What happens is the pressure increases in the ventricles. That increase in ventricular pressure is going to rapidly do something that's very notable. It's going to close the atrioventricular valves. Bang. That's the first heart sound. So now you have, effectively, you have a fixed volume, and now we're just going to ramp up the pressure. And the whole idea of ramping up that pressure by this isovolumetric, not going to get any more fluid in there, is a split-second period where both ventricle sets are closed, the volume remains constant, the ventricles continue to contract, and when the ventricular pressure exceeds the pressure in the large arteries, okay, the valves are forced open. That's, boom, that's the systolic pressure. Roughly in the aorta, it's 120 millimeters of mercury for a typical, like, let's say 20 to 40-year-old person, the model they're typically using, who's healthy. And you can feel that when you take somebody's blood pressure. One of the ways you can tell exactly what that number is, you could hook it up to a machine and find out. You can use the old-fashioned sphygmomanometers where we have the analog readout, that little dial. And one way that you do sometimes, particularly if someone, this is a good teaching tip, when it's hard to get somebody's blood pressure because they're shocky, you put your fingers right over that radial pulse, which is so easy to get. And when you squeeze that blood pressure cuff, boom, 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 let it go slowly. And as soon as you feel that pulse come back, that's systolic. We call that systolic by palpation. Somebody's in shock, you're going to hear him say this here in the ER. Oh, the BP is 80 by palpation, 80 systolic by palp. It's not good. You should be able to measure it more easily than that. But that's another way to get the number exactly, by the way. We do a little bit of this when we talk about blood vessels as well. So at that point, it relaxes early, the ventricles repolarize, and we get a volume at the end of systolic volume, the volume of blood remaining in each ventricle after systole. And you're going to see it's surprisingly more than you would think. That's ejected. Okay, ventricular pressure drops, causing a backflow of blood from the aorta and pulmonary trunk that triggers the closing of the semilunar valves. I'll explain it. Ventricles are now completely closed chambers for brief, and then now you get a relaxation phase, and what happens, and what happens then shortly thereafter, the atrioventricular valve opens and it starts to fill again. We get back to the start. The interesting part is this, is the end systolic volume, and this point that triggers the closing of the second heart set. So if you any way you want to look at it, it works kind of this way. Just arbitrarily going, this is the heart. Just showing diagrammatically for those who are online won't be able to see it. But effectively, you have blood flowing out by way of those valves. This is the aorta, or this is the pulmonary trunk. They are what you're going to learn in the next chapter. Did you do blood vessels already in lab? Not yet? You didn't do elastic arteries, conductive arteries? Tomorrow. Heart, of course. Effectively, these are all elastic connective tissue. It's a trampoline. So when you push that out, you push that trampoline aggressively in both directions. What happens? It's filled with blood. Arterial blood. Look at this. You're out there in virtual land, I'm drawing it in red. So what happens is now you have blood. Think of this as an expansile, like a sort of an elastic straw. What happens? So that effectively what facilitates a nice even flow of your blood pressure. It's not pulsatile in the sense of your blood pressure doesn't up and down, up and down. That would be turbulence. Turbulence makes blood clot. Your blood pressure, as you will see in the diagram shortly, is kind of lazy like that. And all of that comes from the second mechanism that closes the aortic and pulmonary semilunar valves. Okay? So those valves, when the ventricles contract, they push it and expand it. As soon as that contraction is over, and the heart starts to relax, the pressure starts to go out of the ventricles, we get a second wave. Because now, without those vessels being forced open and apart, they relax and they rebound. It's elastic. It's trampoline. So in comes the trampoline, pushing that person back up again. Exactly what happens here. All that fluid that's in the aorta or the pulmonary trunk or the carotid or the subclavian arteries, all the elastic arteries. By the way, that fluid, you have liquid in a straw open at both ends. You squeeze it down in the middle, it's going to push it out toward the body or out toward the lung. But it's not unidirectional. So the valves are here. It's going to push it back toward the valves. And as it pushes it in toward the valves, boom, that's the second heart center. Now it's hit that. It's like waves coming into shore. You hit the waves to shore, boom, and they bounce back off this way. Okay? It's like the undertow you get when you're at the ocean. Okay? Boom, you hit it, and now that creates a second and auxiliary wave. And that makes less of this, as you will see, more of this. Got a fancy name. When we measure the pressure, particularly in the aorta, it's called the dicrotic notch. It is not part of the EKG. It is not electrical, it is mechanical. You will see it. That's the magic of that second heart sound. It basically ensures it's like a secondary wave that creates a more even and balanced flow and facilitates that flow going all over your body and helps it getting on the way back. It's a good thing. Again, if I'm not enthusiastic, why would you be? So closure of the valve, particularly the aortic valve, raises the pressure as the backflow closes the cusp, dicrotic notch. The atria continue to fill. Remember, the valves are shut during that ventricular relaxation. When the atrial pressure exceeds ventricular pressure, the AV valves open. So effectively what happens, the blood's flowing in to the atria, and it's sort of simultaneous with the ventricles relaxing. There's no push holding the semilunar, the atrioventricular valves closed, and it begins to fill. Typical 75 times per minute, variation. Again, 60 to 80. The cycle lasts about 0.8 of a second. Systole, 1/10 of a second. But there's not a whole lot, okay, that's in there. So, I mean, it's about 1/4 of a second total that we really see the heart actively going through its cycle from a standpoint of both electrical and mechanical activity. Then it has to rest for about a minimum of about 1/4 of a second. This is average when that's 75, when you're sitting there or I'm sitting here. For about 4/10. It's a great job. The heart's got a wonderful job. I got to work constantly, but I get nearly half the time off in between beats, minimum. Not bad work, but somebody's got to do it. This is, I think it's out here. So this is just an illustration, it's hard to see. I grant you. There's a couple ways to look at it. First, we'll look at it vis-a-vis this. So in green, you can see here, this is the pressure in the aorta. If you just focus on the green, there's that dicrotic notch. So if you think of your blood pressure as roughly between 120 and 80, and you can see, if you can project this, it kind of goes down. Now, it's relaxed. You're in diastole, relaxation. The heart ramps up. Blood gets pushed out, and it creates, and now normally you would expect it to just go all the way down, but it doesn't. It maintains itself between 120, and it really doesn't get till 80 till it's ready to start over again. And why it's not up and down, is because of that dicrotic notch, which represents that backflow, like shutting the semilunar valves and creating this secondary pressure wave. So even though you would think of it as being another wave of pressure, it effectively softens the turnaround. Is the way I would look at it. In red, you can see the aorta, the atrium, I beg your pardon. There's not a whole lot of pressure changes, a little bit, and you can see that associated with the pressure that closes those first the atrioventricular valves. Not a whole lot of pressure. It's there, and you can read through this. And this is to put it all together. So now you've got EKG. If you flash back, you can see the heart sounds. So just remember where they're located. So remember, mechanically, here is the atria starting to contract. Here is the atria already contracting. And as soon as the ventricles start to contract, boom, that first heart sound, and look at the pressure rise in the ventricle, which would go all the way down, and it does, but the blood flow doesn't coincide with it. The blood flow stays 120/80. That's that secondary wave that facilitates that. And yes, what happens is the ventricles, as that signal starts in the ventricles, you can see up and down start to relax. Why the pressure in the aorta doesn't, again, is that second heart sound that's created. So we see it here. You've got a P wave. This is going to start the cycle. Before that, when it's in pure diastole, okay, there's not a whole lot of the pressure in the aorta is going down to its bottom, so to speak. There's some transient pressure in the atria that are filling, okay? And we could begin to see here, you can see the ventricles passively, because the valve is open, are starting to fill up. Now, here comes the P wave, okay? Electrical events precede mechanical events, so we begin, if this is the start of it, then the mechanical events are here, they begin to fill it up, okay? And so that, and effectively, you're not changing, that's 20%. You're going, it's about the sum total of about 24 milliliters, less than an ounce of blood. What you will see when you're done with this cycle, the ventricles they only fill to about 120 milliliters, about 4 fluid ounces. When we're done, we still have about 50 milliliters left. We basically eject about 2 1/3 ounces every time from the right side of the heart. Doesn't seem like a lot, but we do it constantly and consistently. So here we are. There's a little top off, filler up. Okay, ready to go. So as soon as that occurs, just in time for now the signal to get through the atrioventricular bundle and down the bundle branches, and boom, we get the QRS, and rapidly, remember, it's a very rapid, it's not slow and steady like the atria. It sets it up, up, up. As soon as it overcomes that resting pressure about here, all of a sudden now you're going to see the volume start to, so right about point A, point B here, around 120, maybe a skosh less, it opens up, and finally opening all up at about 120. And you can see the ventricles, it flows out relatively rapidly, okay? And it would just stay that way, particularly going all the way down, if not for that rebound effect of the elastic arteries. Voila. And then, hey, now we're at rest, and we're going to start all over again. Ladies and gentlemen, the cardiac cycle. So the two sounds, closing of the heart valves, first the AV valves. I'm not going to sit there and ask a zillion questions about the cardiac cycle. You're not going to be cardiologists. You're going to learn more about it if you work on a cardiology floor or CCU, cardiac intensive care, if that's your field of endeavor. So to understand, you guys should know what causes the first sound and what causes the second sound. And in between your lubs and dubs is heart relaxation. The mitral valve, slightly before the tricuspid. That ventricle is a whole lot more muscular, dissected it. And you can listen for differences via auscultation, stethoscope in each valve, placed in one of the 4 different regions where you find it. And that's what, so you're down the road, you're going to have to know where those are. You have to know those spaces. That's part, for those of you doing it, when you get into that physical exam, that physical assessment, competencies. Have fun. Stay outside being nerve-wracked. Just say, is that Betsy who teaches it? I don't remember her last name. She's a very nice lady. Heart murmurs, abnormal sounds, because of, we talked about it, some inherent problem with the valve. Okay, it's incompetent, it's insufficient, it doesn't close, there's backflow, that's common. And it has different sounds. Remember, I'm not into the sounds. Listen to them online. Okay, stenotic, too narrow, tight, taut, restricting, high-pitched sounds, as you might guess. Look, we really get an ear for the sounds. Sounds are really interesting. You're listening to them directly. one of the things we did used to use a lot and still do, we do Doppler studies. It's ultrasound. Ultrasound is high frequency sound waves, and you can listen to larger blood vessels like here for irregular sounds. And a lot of times they're indicators of problems in that blood vessel where it may be likely a clot to form. So a lot of times you'll see patients had to go to the blood vessel lab or the vascular lab for Doppler studies. It's a lot. Years ago, we had to inject with dye, which was invasive and dangerous because you could potentially cause a clot to form in either an artery or vein. Now these are non-invasive. Non-invasive is a good word. We have it as testing. So it's a system that was in its infancy when I started to study peripheral vascular disease, effectively 50 years ago. So we're just really learning about that technology. So different sounds, and this is really an important, you must know this. We talk about cardiac output. Cardiac output is effectively the volume of blood put out every minute. Giving you a heads up, when we get to respiratory, okay, and because in between that, when we finish this unit, you're in trouble. We do blood vessels, and then in between that, we do the immune system. So you have that to look forward to when you come back. Not fun. Well, I think it's the most difficult system we do at APC. So cardiac output is the volume of blood. So for an average, 75 beats a minute. The stroke volume, remember it was 120 in there. We eject 70 of it. We call that the ejection fraction. Okay. That's very efficient, mind you. 5.25 liters. Let's say take that arbitrarily as an average. What that means, everybody, is your lungs have to bring in what we call the minute volume of the lung. This is the stroke volume, the volume of air that you move in and out, that oxygen that you move out, you move in, and carbon dioxide you move out have to marry to this. That's why the lungs, pulmonary system, and the cardiovascular system are inevitably intertwined. Just the same way when you're doing an exercise and you go into aerobics, you know exactly what happens. As your heart rate starts to come up doing a sustained activity, you marry your breathing rate to the amount of circulation that's being moved. So you have to breathe that much faster or however you want to do it. That's basically the concept of aerobic exercise, where you can do that for long periods of time and at the same time scientifically exercise your heart to make it function as optimally for whatever your overall physical health may. So the maximal cardiac output is 4 to 5 times resting in a non-athletic people. And this is all about training. I'm trying to think of the way to express it. They just, for you NFL football fans, they just have the combine. If you would go back and look at the combine scores in the 40, in number of repetitions, 225 benching, and all these skill sets that they're testing these athletes in. Oh my goodness. From what it was 30 years ago, boggles the mind. Absolutely boggles. So the degree of understanding fitness and training and athleticism and how to tailor it, not just to football, to any sport, is absolutely, it's off the chart different. There's so much sophistication today. So we are able to understand what we have to do. So this might even be conservative. Okay, we're just beginning to understand what the physiological limits are of the human body, if indeed there are, and there are certainly limits, but just how much we can, impact them and optimize them. So the difference between resting and maximal cardiac output, that's what you want to have a very consistent resting cardiac output, not putting in undue strain, and have a large amount of cardiac reserve. That's the idea of your resting heart rate. So that resting heart rate is, you've been sitting here for a while, check your pulse, get your stopwatch function out on the phone, count for 10 seconds, multiply times 6, and somewhere between 60 and 80, you're doing just fine. So if either of these change stroke volume or heart rate, Okay, those are the two factors. So we look at the stroke volume is typically a result of the pumping ability of the heart, and the heart rate has to do with that pacemaker system we spent some time talking about. And you can just look at these different things. It's a useful chart if you want to look at it. So what's going to increase stroke volume? If we're able to preload it at the end of diastole, do we have sufficient venous return? So I told you going in, I'm a nut about veins. Venous return is very important. That's why we underrate it. 2/3 of your blood is in your veins at any one time. So trying to maximize that getting back is very important. So increasing venous return, other things that can impact that. Exercise. You're going to learn about muscle pumps that we are basically blessed with. Ventricular filling time, slowing down the heart rate, more time for it to fill. And you're going to see very soon something called Frank Starling's law. That's Frank-Starling, two proper names. And all it means, we know about muscles, you learned about it in AP1. If you stretch a muscle optimally, it contracts optimally. You want to stretch it scientifically because the more you stretch it, the more efficient it is to contract. If you don't stretch it enough, you don't generate enough force. If you overstretch it, not useful. You don't have enough contact points. Remember that 80 to 120 in skeletal muscle. I know this is A and P. I know this was, 4 months ago. Go back and look. Okay? And so, other things can influence the contractility of it. In other words, so here we're stretching it. Here, the other factor is how much we can contract it. Epinephrine, thyroid hormones, excessive calcium, it's not always good. And heart rate, sympathetic versus parasympathetic. So those are autonomic, and it could be fight or flight or decreases in blood pressure. So there's different things that guard it. Something you don't, fight or flight, something that's going to happen periodically to people. What you have the ability to control is what is the dominant, and it's the parasympathetic. And again, that's what controls your heart rate. So voila. So here's the stroke volume. The end diastolic volume is affected by length of the diastole and venous pressure. The end systolic volume affected by your blood pressure and the force of contraction. We want to maximize this. Okay, and we optimally keep this consistent, but at the maximum level that is necessary. So again, this is what we call the ejection fraction. We have the stroke volume is that 120, and the end volume is about 50. So we're just pumping out 2 1/3 ounces, 30 milliliters an ounce, about universal. So what are the big factors that influence it? Loading it, the overall contractility, and kind of what's left in it. This is a lot of the science behind it. This is why something simple with patients who might be having trouble or their blood pressure, we probably, it's a fancy name, it's called Trendelenburg. Trendelenburg, when they're in bed, we prop their feet up. Not so hard. It's called Trendelenburg, a fancy name, capital Trendelenburg. We do it in surgery a lot too. We want to limit the bleeding. We want to make sure there's adequate, assuming we're not using a tourniquet or something like that. So preload, the stretch. Cardiac muscle cells are stretched. Okay, it affects what's left after. So the preload affects stroke volume. That's the Frank Starling law of the heart. The relationship between how much you load it and how the strength and the stroke volume is. And it's that length tension relationship. At rest, they're shorter than they need to be. Okay, so filling them appropriately really optimizes contraction. For most people who take care of themselves, you don't have to worry about this. Eat properly, exercise reasonably, you're not overly sedentary. All of those things are good. If you're like that, you're doing well. The difficulty for many of you folks, and I say this sincerely, is many of you have, and unfortunately some have, but a lot, and I was like the same way when you're young, you're not in touch with your own mortality. you haven't had, not everybody's like this, haven't had something happen to them or be part of them where they have to worry about what could go on the next day. It's not something, you just don't see it. There's a certain amount of, and we see this with young folks all the time. They do things, and I don't even know, maybe you read in the paper, a guy who was effectively finished high school early for Pitt, wide receiver, was a top 3 or 4, died in an auto. I don't know the particulars. I don't know if somebody was under the influence. It was just a horrible accident. But you don't think about that. Maybe you're different than I am. We didn't think about that. We did a lot of stupid things. Try to minimize those. I realize it's college. You're entitled to do those. I would never have done that. You're all looking at me like, what? I had occasion to say this to Micro. We all did this stuff. 50-year separation, 55-year separation does not mean we didn't still do the same stuff. Preload, most important factor, venous return. Slow heartbeat increases it, exercise increases it, distends or stretches, voila, Frank Starling law, all good. Contractility, okay, contractile strength at a given muscle length. This is independent of filling it. So it lowers, increased contractility lowers the end systolic volume. In other words, how much, it means less in the heart after it's pumped. So again, epinephrine can do it. Increased calcium makes it available, more cross bridges. The fancy name we give to things that increase contractility, independent of the stretch, are called inotropic agents. So you see epinephrine is in that. This is thyroid hormone is in this. Glucagon, remember we talked about in endocrine? Okay, even extracellular calcium. You don't see digitalis used as much. Years ago, digitalis was a medication that was sort of a first shot for people with heart problems. It had a lot of difficulty keeping it from getting to toxic levels. And now we have better medications, but historically that was relevant. I don't want to go into cardiac meds. You get a lot of that in pharmacology, many of you. And what decreases it? Okay, acidosis. Something diabetics get with, unfortunately, a greater than necessary degree of frequency. Extracellular potassium. You're starting to see calcium and potassium. Very important. Acidity. All those positive charges. And now, one that we use therapeutically, calcium channel blockers. A first go treatment. Not digitalis anymore. The first thing that we use a lot is we try to, when people have an overly contractile heart or they have high blood pressure, which is usually the sign of that, they use calcium channel blockers. I take one. I take a small dose, but I do take one. And I've done so for years. It was one of the early ones that was around. It goes by it's called amlodipine is the generic name. Things you're going to learn in pharmacology are two names. Generic name, which is the name one should use, and often you'll see and the other one is the trade name. And the original trade name for this is called Norvasc. But calcium channel blockers have a very, very important role in medicine today for blood pressure, heart, kidney-related problems. And this is just how norepinephrine works. You don't have to do this. Thank goodness. G protein receptors, etc., etc. And what's left? Afterload. Back pressure exerted by the arterial blood. Pressure that the ventricles must overcome to eject blood. That's what's sitting. That's what does. Remember what slammed those valve doors shut? The aortic and semilunar valves. So there's back pressure from that blood. The aortic pressure is around 80. The pulmonary trunk is around 10. So once you get to 80, you're starting to force that thing open. And by the time you get to 120, it's open. And those ventricles will empty relatively quickly. So hypertension increases afterload. And what you're going to find out, the absolute best measure for blood pressure, and if I say it to you 1,000 times more, it makes it the same importance, is the resting tension in your blood vessels is that bottom number. That's the big number, because whatever that heart has to work to do this. Those elastic vessels, they're being held pretty tightly. Your heart has to have enough zip, pushing that blood out to go boom, boom. If those blood vessels are overly taut, the heart has to work extra. It can enlarge. That's a muscle that gets too muscle bound. We talked about that. And that very much is the situation. So high blood pressure results in increased blood left in the heart and reduces the stroke volume. Bad. So if the stroke volume decreases as a result of decreased blood volume or a weakened heart, cardiac output can only be maintained by increasing the heart rate. So not inotropic is force of contraction, chrono, time, rate. So factors that increase and decrease. So you must know the terms inotropic and chronotropic. Chrono is easy. Think time. Chronos. Chronology, a timeline. This is a term that's familiar to you? Not Chronos with a K. Zeus's dad in mythology. No mythology fans? Theseus, Minotaur, Perseus, Gorgon. Love that stuff. Okay, so we have the autonomic nervous system, fight or flight, versus the parasympathetic, the vagus, chemical agents, other factors. So autonomic nervous system, regulation of the heart rate. Sympathetic nervous system can be activated by fight or flight, emotional or physical stressors. Norepinephrine binds, remember, these are beta-1 adrenergics. Remember those way back from autonomic nervous system? Pacemaker fires more rapidly. End diastolic volume decreased because of decreased filling time. Increased contractility. Okay. And systolic volume is decreased. So obviously you have a limited capability of doing it before significant problems arise. And indeed, that system is only activated for brief periods of time. Okay. So because both EDV and ESV decrease, stroke volume can remain unchanged, at least temporarily. Opposed, as you all know, sympathetic always opposes parasympathetic. Acetylcholine hyperpolarizes the pacemaker cells, opens more potassium channels. Remember that? Leak channels. Boom, they open up, goes down. Makes the interior more negative. That's hyperpolarizing. Slows it. No effect on contractility. Summarize. The sympathetic nervous system, by way of fight or flight, affects with epinephrine and norepinephrine particularly, increases heart rate and increases force of contraction. Chronotropic and inotropic. The vagus, by way of the parasympathetic nervous system, only influences heart rate. Again, your heart rate would normally be over 100 if we didn't have the engagement of the parasympathetic nervous system. Like a lot of biological systems, like the cell cycle, it's a governor. Holds it back. Part of what we do with our bodies, they tend to charge into things. We keep them under check. Basically, that's a very, very consistent thing we see physiologically in the human body. We basically restrain it from doing more than it needs to do. So that's vagal tone. It is dominant, about 25 beats per minute. The heart rate would normally be around 100. And so those are important. So, and basically we know they're opposite one another. They call this the Bainbridge reflex by increased venous return, hence increased atrial filling. Okay. And sympathetic, so as we get more venous return, it actually increases the amount of filling because atrial walls are stretched. Okay, increases heart rate. So there, you get certain sort of side benefits that go along with this. So this is the atrial. I mean, you're getting a little. This is a sympathetic reflex that comes from the increased venous return. And again, a useful chart to show you things that occur without going over it at length. Chemical regulation. Hormonally, norepinephrine is directly from the parasympathetics, but epinephrine and norepinephrine both come from the adrenal medulla, fight or flight. Thyroxine, people, if your thyroid becomes more stimulated, remember, sort of back to endocrine, thyroid plays a role in everything. So it increases heart rate and enhances the effects of norepinephrine and epinephrine. So fight or flight in combination with somebody who's already got an overactive thyroid can have some problems. And then this is what we worry about medically in our chart. Intracellular and extracellular ion concentration. So in order for it to work properly, calcium and potassium, and that's the biggest understatement you can imagine. It has a profound, significant effect. Told you many times, when we start to see irregularities in calcium and potassium, and understand the effects on the conducting system and the effects on the heart vis-a-vis the muscle are different. So you have effects that affect the electrical system and the mechanical aspect of it. So it's very intricate. So you can see hypocalcemia in general depresses the heart. But remember that we have to have enough calcium because the heart relies on extracellular calcium to contract. It's not like skeletal muscle. It's not already in there. Hypercalcemia increases heart rate and contractility. Kalemia, that's how you pronounce it for potassium, alters electrical activity, which can lead to heart block. So, but this is the biggie. Arrhythmias, hypokalemia. So when any of these are abnormal, they have such an impact, not just on all muscle systems, but particularly the heart as well as the electrical system. So not only are you impacting the heart force of contraction, but you're impacting the arrhythmias as well. Same thing here. You have hypocalcemia, and generally it depresses both areas. Other factors. Your heart rate continuously declines with age, perhaps up to a certain point where it stabilizes. And then, we begin to see changes associated with, the fancy term is called senescence or aging. Women generally slightly faster than men. Exercise, okay, typically increases it, but long-term, athletes, particularly endurance athletes who do a lot of, let's say, distance type running, soccer players who run all the time, X number of miles or kilometers every game, cyclists, all that stuff. Typically, because that improves their reserve and body temperature increases. These are all pretty straightforward stuff. This one's interesting. So it's interesting that we listen to the fetal heartbeat with a stethoscope or a monitor. I mean, being at 120, it's going to work its way down. And even when the baby's born, and ladies and gentlemen, my neonatology is I'm not someone who should be teaching. I disqualify myself. Basically, when we get to some of the growth and development stuff, I'll share what I know, but I don't know. So we call anything over 100 normally, not you're working on the treadmill, okay, you're allowed to be tachycardic. You're trying to induce. Depends if it's persistent. So that's the 60 to 100. We talked about normal sinus rhythm. Normal means not over 100, not less than 60, unless you have that athletic endurance training. Okay. And then what's the pitfall of all this? What are we leading to? Congestive heart failure. It doesn't happen like this. We would see it when it happens like that rapidly. Now you think, that's the consequences immediately of a heart attack. You'll hear the term cardiogenic shock. That's typically a heart attack or a major event. And we don't know exactly what the cause was. We'll say a cardiac event so we can define it. And that's, typically that's when it happens rapidly. And cardiogenic shock is bad because there's not a particularly great survival rate. That where most people, it's progressive. Cardiac output is so low that the blood circulation is inadequate. When it's inadequate, okay, we have a great term for it. These are two terms you really have to incorporate for your use, most of you in the field, inadequate circulation is called ischemia. How do we basically use the term perfusion. Perfusion, when it's poorly perfused, that leads to ischemia. When it's well perfused, it means the opposite, very viable. Lives well. So ischemia is an inadequate amount of blood flow, read that as oxygen to function normally. And perfusion is sort of a term we use for either well perfused or poorly perfused. And so a lot of things impact it. We're just about done. And really, clogged arteries, fatty buildup, we'll talk about this next time. All of those things that are there. So we'll go back and look at the things and start here with the idea of congestive heart failure, what goes wrong. And we don't have a whole lot left, a couple of slides. Thank you.